Right, it's just after 1:30. I think we'll make a start if we may. Welcome to everybody for attending this MICRA webinar, the first of a series. We've got three fantastic speakers today. As many of you know, MICRA, the Manchester Institute for Collaborative Research on Ageing, a collaboration of about 300 researchers that really span all aspects of ageing research, from social sciences to biology and from arts to physics. And I think at no time has it been more important in terms of ageing research, and we should remind ourselves that in Manchester we're at the centre of the first WHO accredited Manchester city and region, so it's a very important time. The issue of COVID is among us. We would normally have these things face to face, but we are in a different place. And the webinar we're going to have now is really to talk about some particular aspects of COVID around ageing. I think you probably all know, in terms of the question and answer, we've got three 10-minute presentations, and then I'll broker some of the questions for 10 minutes after that. We are recording it, and this will be available in the future. So thanks again for everyone for attending. So our first speaker, it's a pleasure to introduce a colleague, Professor Ronnie. Ronnie is Professor of Medical Sociology at the University of Manchester, and his research is largely around the social determinants of health, focusing on health inequalities and psychological factors, with an emphasis on stress at work. I think looking at longitudinal data is one of Ronnie's strengths as well, and it's a pleasure that Ronnie is a fellow director at MICRA. So Ronnie, your presentation in terms of stress and work is really important during this area and this time, so I'll pass over to you, if I may.
Okay, welcome everybody. Hopefully you can all see me. I'm just going to make my presentation visible to all of you. So hopefully you can all see my presentation. Thank you for listening in on this webinar, and I'll be talking about the impact of COVID-19 and the subsequent measures to deal with COVID-19 on the well-being of older adults in Britain. And it's particularly important because quite a few people have written about this. You know, the potential impact of shielding and lockdown. So the idea is that with the stay-at-home policies for governments around the world, which these governments have been strongly urging older people to stay at home for an extended period of time in isolation or shielding to reduce the risk of infection. However, most older people are dependent on support from communities and carers in terms of maintaining their daily routine, staying active, and having access to daily living essentials like food, personal care items, and medications. So the physical distancing restrictions limits the activities older adults can engage in, can result in a loss of their freedom and reduces their social engagement, so including access to their closest family members. Moreover, we know that many older adults do not have easy access to digital platforms and virtual communication methods. So it's very likely that the physical distancing measures are likely to result in lower well-being and greater social isolation among older adults. And if we look at some of the reports that have been coming out, for example, in the media, this is from the Guardian website a few days ago, where they got their readers to write in about their experiences of lockdown, and a lot of the reports in that particular media report was about the older people's fears of their extended lockdown. There have been a few surveys that have come out, typically done by interest groups. So this is from the Elder magazine, which surveyed 500 people over the age of 70 in the last 2 weeks of April. So it's quite recent. And the headline figure was that 1 in 3 elderly people are more lonely in the wake of COVID-19. So that's quite a stark figure. 1 in 3 older people over half as less likely to be in contact with their family, 3 times more likely to fear being left alone, over a quarter finding getting groceries more challenging than before, 28% aren't confident with using digital technology, and 1 in 5 of the over 70s are speaking with their family or friends less than fortnightly. So this is a picture that we're getting that, that older adults are particularly being, their well-being is being affected by the pandemic. But I came at this because I'm very interested in the statistics and the data underlying these numbers to examine, well, it's true, older adults could be affected, but so is the rest of the population. Younger adults are also facing their own kinds of stressors and so on. So I was interested in looking to what extent are there sort of more valid, more reliable forms of data that support this picture. And very recently, this data set called the Opinions and Lifestyle Survey has come out. It's an ongoing survey. It's very frequently done in Great Britain. So it covers adults aged 16 and over in Great Britain. The sample size is not bad. It's about 1,300 respondents, but more importantly, it's representative of all the countries in Great Britain, and it's meant to take account of the survey design and non-response to make the survey representative of the populations in these countries. This survey has been going on since March, the special COVID-19 module, but this survey has been going on for many years. So it's a very well-respected, well-used survey, and in particular, during this COVID-19 period in March and April, it serves as the most high-quality data that we can get on people's experiences and reports of well-being. So here are some headline figures in terms of trends, and you see in terms of these indicators, it's pretty much a flat picture from the 20th of March until the end of April. Around 80 to 90% of adults say that they've avoided physical contact with older and vulnerable adults in the past 7 days. There's been a slight decrease in the percentage of adults that say their well-being is affected by COVID-19, and a slightly more marked decrease in the percentage of adults with high levels of anxiety. So for that green line over there, we see it goes from about 50% with high levels of anxiety in 20th to 30th of March to around just under 40% towards the end of April. So that's a decrease of over 10%. So it actually looks like people are reporting lower levels of anxiety. And in terms of loneliness, it looks like a pretty flat picture. Well, this is the picture for all adults aged 16 and over. What about the picture for adults aged over 70? So on the brown bars, we have the figures for people aged over 70, and in the blue bars, we have the picture for people aged under 70. And here, now, if you look at the left-hand corner, we see that there is quite a big difference between the percentage of people who are worried, or how worried or unworried they are about the effect that COVID-19 is having on their life right now. And here we see the picture is that the under 70s have a much higher rate of feeling worried about the impact of COVID-19 compared to the over 70s. So that's over a 10% gap. And this is a picture that sort of translates through many other questions in this particular survey. These are the standard well-being questions that the Office for National Statistics asks. And for 3 of those indicators, the positive ones, overall, how satisfied are you with your life nowadays? To what extent do you feel that things you do in your life are worthwhile? And how happy did you feel yesterday? There's a very clear difference between the over 70s who score much higher, so they have higher levels of well-being compared to the under 70s. There's just no difference between anxiety levels between the 2 groups. In terms of support from local community members, again, it's very clear that the over 70s are 50% of the over 70s strongly agree with the statement that they feel supported by the local community, compared to 30% of the under 70s. So that's a 20% gap that we're finding over here. And in terms of loneliness, there's an interesting gap that's emerging. So in the survey towards the early to middle of April, from 9th to 20th April, there was no difference in the percentage reporting feeling lonely often, always. But towards the end of April, the under 70s, that percentage increased from 4% to 6%, so increased by 2%. Whereas for the over 70s, that percentage decreased from 3.5% to around 2%. So you see that the feelings of loneliness, it seems to have increased in the under 70s and decreased in the over 70s. So what I'm trying to say is that we're getting a picture from the surveys, from the high quality survey data, that's very much at odds with the picture that we're getting from media reports, that we're getting from bespoke surveys say, older adults interest groups. So we're finding that the older adults' well-being indicators in Great Britain are actually better than those who are under 70 years of age. And actually, there's some suggestion that the well-being of older adults is actually improving as lockdown progresses. So, I started off with this idea that, well, yeah, it kind of makes sense that maybe the well-being of older adults are affected a lot more than by the pandemic. But actually, it's always important to look at what the data are saying. And I suppose that's my take-home message from what I understand of the impact of COVID-19, is that we're just getting such poor quality data through, and we're a lot of us are basing our judgments on poor quality data and poor quality surveys, and so we need to really examine much better sources of data in order to have a proper understanding about what's happening with COVID-19 and its impacts on our lives. Thank you very much.
Okay, Ronnie, that's very helpful. I'm aware my video's not switched on. I'm trying to preserve my bandwidth, so if I'm here, so but I'll try and preserve things. So please, if you've questions for Ronnie, just if you could pop them in the Q&A box, that would be extremely helpful. I'll start, if I may. Ronnie, absolutely fascinating. In terms of you have an expertise in looking at longitudinal data, and clearly that is often over years, whereas what you're describing so well is weeks and sometimes days. Yeah. Do you think that can affect the way that we kind of think about that information, and that what we're doing now is concentrated in such a short time scale?
Yes, you're entirely right. So what I presented to you isn't longitudinal data. So it isn't following up the same group of people from March onwards. It's a repeated cross-section of the population of adults age 16 and over in Great Britain. So it's hard to say that this is really a longitudinal picture that we're actually witnessing an improvement in the well-being of older adults or decrease in the well-being of younger adults. So for that, the data, we will have data soon, not right now. So from very good surveys like the Understanding Society survey, so we will have very high quality data that are population representative, that are on large samples, with which we will be able to actually look at the changes in mental well-being and physical well-being in recent months over larger timescales. But actually, even from this high-quality data set, what we're getting are snapshots of well-being in the population in the constituent countries of Great Britain. But you're right; it's not actually recording an increase or decrease of individuals' well-being.
Great. We've had a couple of Q&As. One is saying there's no question, but it was a wonderful presentation, so that's great news. Louise Mitchell's said, are there any, if you had asked further questions with the participants to try and gauge why they feel this way, do you have any sense as to why they might? Is it because of use of digital technology? Any thoughts on that, Tarani?
Yes. So, yeah, I think the question around digital technology and its uses is very important. And there are some more detailed questions in this particular survey that I was using, the opinions and lifestyle survey, that does go into more depth about specific aspects of loneliness. My own personal view about digital communication is other people have this as well. So because of the digital divide, I think, yes, digital communication, virtual communication is helping some people, and especially some older adults, but because of the digital divide, that's only true for certain groups of people that are more used to having these devices and have these devices and a good internet connection around.
Right. And there's a question come in as well. Do you think, if you took into account, Ronnie, things like people who lived alone, the type of housing, city versus rural, do you think that would affect the results very much? And I mean, drawing on your huge experience in the way these factors affect things before, any thoughts on that?
Yes, it's such a good question. So the results that I presented are not don't control for anything. So they're just straightforward results from the survey. The data have not been released as yet, so I can't do any fancy statistics on them to control for these very important things like living alone and housing type and urban rural. But from my experience, these kinds of differences that we're seeing, differences between younger and older adults, where there's between 10 and 20% difference in the responses to some of the categories. I think that's unlikely to go away by controlling for many things. Some things will explain the differences between younger and older adults. But for me, perhaps what might be a more interesting question, but maybe not so relevant for this audience, is why is it that the younger adults, there will be some groups of younger adults who are whose well-being has decreased and who are feeling more isolated and lonely in these times, and I'm very much interested in finding out what's causing that, and maybe things like their working conditions, their financial situations, their household living arrangements, those things could explain
right.
why.
That's great. We've got a couple more questions, and I wonder if you were able to answer them pretty quickly, because one of my jobs as chair is just to keep on top of the timing. So there's a question in that I suppose that this would potentially bring out the issue of health inequalities, which was helpful. One question as well: do you think that older people are less likely to reply in a particular way in terms of saying that they were, very worried? Do you think that there might be generational issue at play?
Yes, so that's such a good question. So we know that in general, older adults tend to report more sort of higher levels of well-being at a particular age, say from post-retirement to age 75 or so. That there's a marked improvement in their well-being, and that might be a generational effect. That might be an age-related effect. So it's hard to distinguish generational differences from just cross-sectional survey questions like the one that I've been using.
Okay, that's great. That's great. There was a question, Ronnie. Someone asked if the data would be deposited with the UK data service, and Patty has said that we might be able to do some more fancy statistics soon. Is there an opportunity, do you think, Ronnie, for some fancy statistics?
Yes, definitely. So I'm pretty sure that the previous waves of this survey are available from the UK data service. So it will be deposited fairly soon for people to do more robust analysis with the data. And I can see that there's a question about selection bias in the survey. So the survey is actually a very good survey. It doesn't capture everybody. So it doesn't capture people in care homes. So it doesn't capture people in institutionalized populations. It doesn't particularly capture Black and minority ethnic groups very well. So as soon as you start going down to much smaller categories, it doesn't represent those categories very well. But it is a very good snapshot snapshot of adults living in Great Britain in standard private households.
Great. And there was one question from Jay. Would it be possible that one reason for older people not feeling as much difference, as you showed very well in the last slide, that in fact older people haven't been able to get out?
Yes. So yeah, it's definitely true that if you look at the other questions, that older people do report that they're not able to get out as much as before. So that should definitely play into people's levels of well-being, but it doesn't really explain why younger people seem to be reporting higher levels of isolation and loneliness compared to older people.
Great. Tari, that's absolutely fantastic. It's amazing the amount that you've been able to get through. If you were at the number 10 briefing, Tarani, and you were able to say one thing that you think that SAGE, the advisory committee, should do based on your information, what's the one piece of advice, Tarani, that you would give to our Prime Minister? I'm sorry to put you on the spot.
Yeah. So, gosh, I'm afraid I have to be quite boring. I'd say, we need better data. So right. It's just the kinds of inferences people have been making policy decisions on is just based on such poor quality data.
Right. That's a great message, and I suspect that's the thing that we'll come back to. Tarani, thank you very much indeed. And we will get a report of all asked, and if there weren't any that we were able to answer, I promise we'll be able to answer them afterwards. Okay, Tarani, thank you very much indeed. Our next speaker is Professor Katherine Robinson. Katherine's Professor of Social Care Research at the University of Manchester and a co-director of the Institute of Health Policy and Organisation. She's also one of the associate directors of the National Institute for Health Research School on Social Care Research. Katherine's research interests are looking specifically at the interface between health and social care, family care, mental health and suicide. So shining a spotlight on that for us, Katherine, in terms of the current issues in COVID will be really important. Over to you. Are you there, Katherine?
Yeah, there's nothing like being able to use your own technology, is there?
Right.
So, okay. So I'm delighted to have been invited, if not a little daunted. And now it all worked earlier and it's not progressing. You see, oh, there you go. Okay. So I think as Tarani's presentation has demonstrated, I think research about the pandemic that includes work from social science is important, and it will continue to be important. I think the context of inequalities is relevant right across the age range and indeed the workforce, and in particular with older people. I think it's important to understand how things have unfolded, and of course there are different narratives, there are different ways of looking at what's happened. And what I'm going to talk about is some of the things that I'm thinking about and the context that I think will continue to be important for the research that I'm involved in, or research that I'm planning. Infection rates, numbers of deaths, policy shifts, testing, but apparently not test, PPE, availability and quality have really dominated news reporting in the UK, and to some extent quite a lot of discussion amongst researchers. I think we'll all recall that the first recorded case was the 10th of December, doesn't seem that long ago really, with the first death reported in China a month later. And then if we come to the UK, the 22nd of January was the first meeting of SAGE in the UK, and the connection, of course, with senior members of COBRA. And then a few days later, Imperial College London team were talking about a clear and ongoing ongoing threat. A month after that first death was reported, WHO in their reports talk about the name of the virus and the disease. And then towards the end of February, Marmot, 10 years on, his report launches, very much seen as a watershed on inequalities, but has somewhat got overshadowed really with what's happened with the pandemic. I was delighted to be invited to his launch event, but unfortunately wasn't able to attend as I was in the middle of a site visit to India. Around that time, the reports of deaths in Italy were appearing, and commentary about cases right across different parts of Europe. And I began in India to be quite worried about whether travelling had been, such a good idea at that time. By early March, I'm back in the UK, and things apparently are calm in the UK. And I'll just offer one example of that. A survey of the general public suggested that only about a third of people involved in that survey were concerned about large public events. Two-thirds thought that they should continue, shouldn't be cancelled. However, by the 17th of March, again, the Imperial College London team published and shared, first of all, with SAGE, and then with the general public, their modelling and how serious the pandemic was going to be if it wasn't addressed. There was talk about the 20,000 deaths as being a good result, and suddenly everything changed. Although really, I think my recollection of it is that things changed quite slowly. There was lots and lots of talk about decisions following the science, and that policy decisions were based upon the science. But of course, we know that's really complicated. I think if we consider that the quality of answers are often dependent upon the quality of the questions, and I think that applies as much to policy making as it does to the research that we do. Politicians are not passive recipients of science. I guess in due course, a public inquiry might explore that in further detail, and we may take our own view about that. I guess some of the questions might be, did the government assume we had more time? Did the government assume that we had more control over the development of the epidemic? Were those assumptions realistic? Of course, some bits of the machinery were more questioning than others. And at the end of March, the Health Select Committee discussed issues about PPE, discussed issues about the social care sector's capacity to deal with what was to come, and noted in particular the problem around testing of people who had been discharged from hospital, some of whom had been discharged into to care homes. And by the 27th of April, the UK was rapidly approaching that 20,000 figure, but only in hospital deaths. Less than 10% of those individuals were under the age of 60, with the death rate rising sharply with those over 80. And it was at this point that the repeated demands to publish data about deaths in the community, and in particular deaths in care homes, was agreed to. And the numbers, I think we're all aware that the numbers are stark, and that there is an acknowledgement that the COVID registered deaths are going to be an underestimate, a considerable underestimate. So COVID-19, there's been lots of talk about, we're all undergoing lockdown, and we're all facing this difficulty, and it's a great level. Well, it isn't, and I think we know that. I think we know that inequalities are intertwined. The more severe symptoms are likely, and death is more likely alongside existing inequalities. And of course, we know that developing a long-term health condition or multiple long-term conditions are not solely age-related. And the responses to the virus also create risk. Chris Phillipson talked about older people being doubly locked down, and Ronnie talked a little bit about some of those effects, and some of those effects may not be what we expect. I think the responses to the pandemic have also changed how people die, and I think there are many accounts of people dying alone without that comforting presence of family, both in hospital settings and in care home settings, and indeed in the community. And then what of the response to social care and the policy response to social care? And some of the things that we might need to consider in terms of the research that we do, both in the immediate, but certainly in the medium term. I think I've written somewhere else about the tail of COVID with an I, and also the tail of COVID with an E, being something that's going to be long term, that's going to be with us for some time. Now, one of the early responses from government was to relieve local authorities of some of their existing statutory obligations. So substituting, and I summarise here, substituting a minimal obligation not to cut support below the level required to maintain basic human rights. And there are examples of some local authorities implementing what's described as easement of the Act. And you might counterbalance that against where was the injection of cash for the care sector. And there was some provision, but that provision was related to enabling early discharge from hospital. And as we know, and the descriptions elsewhere about that seeding the virus in care homes in particular. And that's something that we'll continue to look at and continue to talk about. There's lots of figures being bandied around, anything from 30 to 40% or more of all coronavirus-related deaths appearing in care homes. And also, not that this is a competition, but also that the fatalities in social care staff exceeding deaths reported in the healthcare sector. But taken together, it's something that needs to be looked at and continued to be considered in the research that we do. And looking at the social care workforce, there have been lots of tributes from the general public about how well considered that care staff are, how considered that the NHS staff are, and tributes from politicians. I don't want to undervalue that in any way. And people have talked about, I think it might have been Chris Phillipson, talked about that at last the care sector has been recognised. It's underfunded and it's fragmented, but it is being recognised in a way it hasn't been before. And that is strong acknowledgement that the care sector is inextricably linked to the NHS, that you challenge one area of it or put pressure on one area, then it affects the other area. When the care sector struggles, do NHS beds fill under different circumstances? If you look at the care sector per se, it's made up of large companies at one end and small, maybe struggling, family-run businesses at the other end. There are nearly 500,000 care home beds in England, a mixed arrangement for domiciliary care, a small number of charitable organisations and fewer council services. It's a complex workforce. There are 1.6 million care staff, and about 70 to 80% of those work in the independent sector. I don't think you need to describe that pay is low, and there are some estimates that suggest nearly a quarter of people working in adult social care are on 0 hours contracts. I think inequalities, we need to think about not only older people and people who are supported by the care sector, but we need to think about the care sector itself as well in our research. And the whole issue of PPE, I think, continues to be an issue. It appears it was a low priority at the start, despite the high risks, both for residents and for staff. And again, I think that's something that will continue to be an issue. I suppose, for me, the issue of inequalities is about ensuring, if we go back to the idea that asking the right questions is as important as what the answers are, and if you don't ask the right questions. And so the research that we do needs to include things that are relevant to inequalities and that do bring inequalities into that sharp focus. Thank you.
Okay, Katherine, thank you very much indeed for putting the spotlight, and a great set of references there for putting a spotlight onto an area that's extremely important. That's great. Thank you very much indeed. In terms of, there's been a lot said about the issue of the NHS versus care homes, and it was said, I remember at one of the briefings, that one of the challenges was that you've described very well, 400,000 to 500,000 care beds, you know, many more than in the NHS, but it is, as you've demonstrated, quite a heterogeneous service, big providers, small providers, and it was suggested that that might have been one of the reasons why it didn't really have a cheerleader, was the phrase that I had heard, where the NHS is one thing, whereas social care is a group. Do you think that could have contributed to some of the issues that you've raised so well?
I think so. I think it highlights really the, you know, who is responsible, and you know, there's a difference between contractual responsibilities and how the whole community and the whole sector needed to rise to a challenge. But to expect the sector to do that without coordination and without clear leadership, which appeared to have had some deficits to it, I think it is important. Excellent.
I'm conscious of time. I'm just looking to see if there's any specific questions. As we said before, we'll be happy to gather the questions together. But Katherine, a fantastic summary. And in fact, it's interesting, as you went back, it's so easy to forget all those dates and where we were doing. And it's a bit like when we were talking about longitudinal analysis. We're doing things in weeks and sometimes days. So it's fantastic just to get reminded of how things went. And again, same question to you as to Ronnie. If there was one piece of advice, so Ronnie has mentioned the issue of data. If there was one piece of advice that you could give to Sage, Katherine, what would it be?
I mean, absolutely agree with Ronnie. Better data, share the data, make the data open. But I think the most important message for me will be that this is a snapshot in time, but it is going to go on, and that what happens and decisions that are made need to be looking to the future as well as the immediate need.
Great, and I know a lot of services from the where I am are looking at different ways of doing things, and people now talk about COVID not being a pandemic but being endemic. Katherine, thank you very much indeed. Absolutely great. So we'll move on to our last speaker, and it's a pleasure to introduce Debra Price, who's Professor of Social Gerontology at the University of Manchester, past President of the British Society of Gerontology. Debra trained as a barrister, so we'll have to mind our P's and Q's, but turned to become an academic, which was a great benefit to us, particularly looking at poverty among pensioners, and looking at gender and finance across the life course, and particularly those changes as they are today, Debra. will be really crucial. Debra is credited at giving me the hardest job I've ever had, which is to follow her as being the director of MICRA. Such a fantastic job, but I'm trying to do my best. So Debra, over to you, and thank you very much for speaking to us this afternoon. You might switch yourself off mute. Debra, could you pop yourself off mute?
Yes, I can. Sorry, is that working? Can everybody hear and see me?
Yeah, that's fine.
Okay, perfect. Well, thank you very much, everybody, and thanks for coming and welcome to my home. I think our somewhat bizarre tours that we're having of everybody's home. And thank you very much, Alistair. I want to talk for my 10 minutes about gender, ageing and COVID, because I think there are a number of very important things to be thinking about for those of us who are interested in gender inequalities in later life. The first thing I want to say is that in the gerontological, social gerontological sphere, we're always thinking about the life course, about trying to understand the trajectories that lead to inequalities in later life, which often start very early in life with a series of accumulated advantages and disadvantages. And this is really evident in the field that I've chosen to study, which is material resources, pensions and income in later life. In a way, you can think particularly of your pension income as something that you had to start, that you started building the moment you started work, and what you end up with is really your life's accumulated resources. What we know about ending up with not very much money in later life is that income disadvantages in later life are linked to other disadvantages. For example, in participation in society, in housing, in morbidities, that's how sick you are, how ill you are, how many disabilities you have, and your health. And the trajectory by which this tends to happen, this income poverty tends to happen, is usually due to care, which is undertaken mostly by women, especially motherhood, but also to work and partnership histories, and all of these things have cumulative effects. So when I'm trying to think now about COVID and gender, I think there are two really important questions. The first is we need to understand how COVID will disrupt the life course, potentially reversing gains that we've made in recent decades towards gender equality. We also need to understand, therefore, the impact on care and the impact on divorce. And the second is, of course, we need to understand how COVID-19 will affect older women now with their accumulated advantages and with their accumulated disadvantages. So this is an especially complex issue to debate right now because COVID-19, as we know, is making men sicker and leading to greater male mortality at all ages, and these differences are. So that means that the focus so far in the public domain has been very much on men. And this has included in the social science spheres some discussion of exaggerated masculine behaviours in the face of catastrophic threats. For example, less hand washing, less social distancing by men, with a view that the war metaphors that we're seeing really don't help with this. But of course, there are also health discrepancies, obesity discrepancies, and so on. And there may be a genetic disadvantage. But all of this discussion of men is potentially marginalising the substantial disproportionate impact of the virus on women's current lives, and especially the long-term scarring effects on their life course trajectories. And this masks, this focus on men is also masking important gendered issues that are arising for older women. So I've got two slides about life course factors and then one about current factors. And if anybody wants any more information, obviously this is a bit of an overview, and then of course just do contact me. I can give you more information about this. So the first thing is the life course factors. We are seeing gendered impacts already in pay, sickness, mortality, and risks of unemployment. And this is largely, the first three are very much focused at the moment on the health and social care workforce. 77% of the health, which means these people have very high exposure to the virus. The health workforce, 77% of the healthcare workforce are women. Social care workforce, it's 83% of the social care workforce are women. So whenever we talk about social care and healthcare, we are talking about a gendered issue. And some of you will have seen the Office for National Statistics report that the social care workforce is twice as likely to die as the population at large. They remain largely unprotected, they're very low paid, and they have very poor working conditions. And I think some of the aspirations that this will lead to greater recognition of the social care workforce, I think, might be somewhat optimistic. But the second thing is that the industries that are hardest hit and where most redundancies are now expected are feminized industries. An early study by the IFS Institute for Fiscal Studies has shown that in a particular week in April, 17% of women were made unemployed versus 13% of men. I mean, these are very substantial numbers. And we know that the companies that may not recover when the support is withdrawn are feminized: hospitality, non-food retail, childcare and tourism. And we all know that the worst is yet to come. But also, people don't always realize that the gig economy and the insecure economy is feminized. So women are 70% of low earners, more than half of 0 hours contract workers, and 74% of part-time workers. And we know that lifetime low pay severely impacts on later life welfare, even if you're in long-term work. The New Economics Foundation has recently reported that of the 1.6 million people who they estimate are at high risk both of losing jobs and not qualifying for any job support, women's risk is 30% higher than men's. We know with all of this that gender pay gaps are likely to increase, and of course ongoing issues with problematic funding and structure of social care. But I think the other life course factors that are always less talked about are what happens in the black box of the household and how does this impact what happens next. So the gendered roles at home, especially now with childcare, with school closures, and the depressing effect on productivity, means that women have an inordinate fear for their jobs. And if children remain at home, it is very likely that it will be the mothers who sacrifice jobs and careers. They are also likely to be penalized in selection for redundancy or dismissed if their jobs are not legally protected. And the other side of this too is that we are expecting thousands of childcare providers to go out of work, to fold permanently. So the impact on the childcare market may be long-term, cyclically impacting women's jobs. Lone parents in particular, already 45% of they and their children are in poverty. Of those in poverty, 90% are women, and they're currently under great stress. We expect mothers and children's poverty to substantially increase, and nearly 20% of children in the UK live in a single parent household, so this is not a minor issue. I'm not going to talk more about domestic abuse, but this is a major concern. I think less heard about is that we will definitely have an increased risk of divorce after lockdown, and we know that this catapults women into low income and poverty with long-term scarring effects on their resources. So to sum this up before my last couple of slides, how important are lifetime histories of paid work for income in later life? How worried should we be? The very short answer is very worried. This is likely to cycle into substantial differences in women's pension income and substantial differences in their ability to maintain involvement with paid work in mid and even later life, depending on the economic consequences of this virus. So I just wanted to spend a minute or so highlighting some gender issues for currently older women. The most important is that care home deaths are a gendered issue, and I have not seen a single word written about this. We know that the vast majority of care home residents are women. We don't know how many. We know far too little about pathways to care homes, but from research done on the 2011 census, it's likely to be disproportionately poorer women without partners or adult children. What this means is that if your risk of dying in a care home versus dying at home with a carer is much higher, this is a gendered risk and is likely to be because of your lifelong gendered disadvantages. But on the other side, 70% of women over 80 live alone, and they are currently at high risk if they become ill, especially if they become ill with COVID. It's a hugely disproportionately a female issue living alone in later life. For those in couples, domestic abuse is virtually undocumented in later life. Caring for adult children and caring for partners, people currently have little help. Services have been cut or stopped, and the anecdotal evidence about this is very distressing. I also think there's an issue now that we're only starting to learn about the long-term consequences of male partners surviving COVID-19, potentially with long-term serious morbidities. Are we seeing a new widowmaker? Definitely, and catapulting of widows into severe financial consequences is an undoubted consequence of this virus. And other things like the lack of exercise will particularly, sorry, that's telling me my 10 minutes is up, particularly have an effect on older women who suffer with much greater levels of morbidity than older men. So my conclusions are, yes, we are seeing we should have serious concerns about disruptions to women's paid work, disproportionate impacts of job losses, recession, divorce, poverty, and these ramifications are going to be felt in later life for the affected cohorts and potentially for their children. But there are also serious issues occurring now for older women behind closed doors, both those who are living alone around morbidity and dying, and for carers, and for those suffering domestic abuse, and the deaths and other issues in care homes are gendered issues. I have to Ronnie's plea for data. Our data on some of this is terrible, but it's very important that we collect it from now, that we can track these things as they're happening and think about policy responses. Thank you very much.
That was great, Deborah. Thank you very much for bringing a really important issue, which I hadn't quite kind of understood it, but you have really brought it to life in a very significant way. That big change across the piece, that's so important. A question was asked. The senior leadership team had observed that during this, the research income of women academics had gone down, research incomes of male academics had gone up. Any thoughts on that, Deborah?
Yes, so this issue is now quite, it's being well documented. There have been a couple of research papers about it, and it's certainly the editors of journals are noting it anecdotally, and some people are gathering that evidence. So that academics, of course, the first thing they can immediately see is what's happening to themselves, and then we can think about it more widely. But it's not a surprise because women are adding childcare and home care and looking after the house, this is always a gendered issue in every home. Maybe there are a few where it's not, but that means women's productivity will go down and potentially men's productivity will go up. And in academia, at least, we seem to be seeing hard evidence of that.
And Deborah, I wonder if I could ask you, in terms of your experience, what's the most effective way of getting this message out, as it were, we've heard the call for better information, but in terms of getting this message out and the importance to change things, what do you think the key factors are in terms of getting this out there?
I think it's very hard, Alistair, how do you influence policy? I think and the public messages. Some of the current depiction of old people as very frail and needing support, the whole wrinkling hands thing, I think is really not helping the public message, because the older people are being conceptualized as being very near to death, so I think there's something about a change in the way the media and policy reports and research reports depict older people, which humanizes rather than dehumanizes them. I think that's one thing. I think the second thing is coalitions of policy actors. The Forward Society is trying now hard to build coalitions of 50 or 60 policy actors that can perhaps try and influence the government. But for all of that, you have to have a government that's listening, and you know, gender issues in the workplace have not ever really been part of this government's agenda. Trying to close gender pay gaps, trying to enhance the work of women. So there's no reason to think it will be now. And there are probably a lot of people in government who think women should be at home looking after their children still, the people who have that attitude. So what you can try and do is build coalitions, arguments and evidence for when you have governments and civil servants that are receptive to that. But the evidence base is absolutely crucial. We saw it with women's pensions. The evidence base was built over 20 years of people going until it became irrefutable, and something had to be done about it.
Right, that's great, Debra. And a question's come in, it says, thanks, and issues of sexuality and older lesbians in care settings particularly. Any comments on that, Debra?
Yeah, so thanks for the question. It's not, I haven't seen any COVID-related research coming out on this, but I know there are a number of people interested in it and looking at it. And there are also some large European studies that were already underway about sexuality in care homes and among older people. And I would be pretty confident that they will now be re-steering that research towards the COVID impacts. So I think we will see things on that, but it may take some time. Great,
that's helpful. And Julia Kate, who asked the question, I'm sure if you were to contact Debra afterwards, we could get something started. Okay, well, thank you very much indeed, Debra. And again, just before you go, your one piece of advice to Sage. We've had not necessarily more data, but better data. A message from you, Debra?
I think it's about so I've had more time to think about this than my colleagues, Alistair. I think it's about legislative protection for mothers' jobs before we're back to some sort of business as usual. Because I think for as long as children are off school, or parents, you know, perhaps rightly, will not send their children to school because of other risks in the household to the children or to themselves or to teachers or to other staff. I think during this COVID pandemic, if we don't somehow legislatively protect women's jobs, I think we're going to see terrible work inequalities.
Okay, Debra, thank you very much indeed. So that's us out of time now. So it falls to me to say thank you to the three presenters, to Ronnie, to Katherine and Debra. And I think you can see how we've packed so much into an hour. It's remarkable what you can get done in an hour. I think seeing the effects on older people has been really important, and those surveys, to Ronnie, that are out there that make the issue. We know it's older people who are at more risk of the perhaps developing COVID. Certainly the mortality has increased, so that importance and the emphasis on mental health and loneliness, to Ronnie, very well taken. Katherine, the reminder about social care and the issue of that issue kind of almost playing catch up with some of the other things. And thanks for the timeline, Katherine, to remind us of what's happened over the last few weeks. And Debra, thanks very much for an incredibly important discussion about inequalities. And as has been said, Katherine, your slide, the issue of COVID isn't a leveler. COVID has brought out inequalities, and if we could use this to shine a spotlight on some of the things, that's really helpful, as the three of you have done. So we're hopefully, if people think this has been a success, we'll be doing more of these on a variety of topics. If you have any particular ideas, please let us know through the website or through people you know in MICRA. Thanks very much to Kerry, to Suzanne and to Alex at Remote Audio for making it happen and making my job the easiest one. Certainly a lot easier than following Debra as director of MICRA, because she did such a fantastic job. So we'll let you know when the next webinars are. So thank you all very much for taking part, and enjoy the rest of the day and the rest of the week.